Good afternoon, everyone. Thanks for calling in online. And this is the Internal Medicine Grand Rounds. Today is Thursday, November 17, 2022. Again, thanks for a great attendance last week for Dr. Syme's State of the Department address. It's very successful, and over 300 people attended either in person or online. So thank you all who attended for that. Today, we are pleased to have one of the Clinicopathological series, conference series, the CPC case series. And these are hosted by our internal medicine chief residents here at BCU. So without further ado, I'll just go ahead and introduce Dr. Reed Alley, who is one of the internal medicine chief residents and interested in cardiology, to take us away. I will put the code in the chat box and also a few other things as reminders. Dr. Alley?
Thank you, Dr. Bergman. Thank you all for joining my Grand Rounds Clinicopathological Conference. Again, my name is Reed Alley. I have Dr. Bahnsen Miller joining me here, and I'll introduce him here shortly after I go through my case. So my case, the format is we'll go over introduction of the case for about 5 minutes. There will be a case discussion by Dr. Miller for about 25 to 30 minutes. And then I have two case experts joining us today, and then a final 5 minutes for Q&A. So the case today involves a 71-year-old female presenting with generalized weakness, fatigue, and progressive dyspnea. And I'm going to borrow an organizational scheme from one of my mentors over at the VA, Dr. Pat Fadden, who likes to kind of use a foreground and background approach to organize a patient's presentation. So our patient presented to an outpatient provider for follow-up, at which time she noted generalized weakness and fatigue. These symptoms had been slowly progressive over the last several months and were now quite debilitating for the patient. She was now limited in her ability to do simple activities such as grooming herself and standing from a chair. She also noted new worsening of her chronic dyspnea with minimal activity. Additionally, her son had noticed that on several occasions during this time period, he had appreciated the patient's hands appearing pale and cool to the touch. So some background, though, on this case: her recent encounters with the healthcare system were notable for an outpatient encounter 9 months prior for dyspnea with right upper lobe airspace disease on imaging. This was initially treated as a pneumonia. However, her dyspnea was refractory to multiple courses of antibiotics, and progression of the infiltrate was noted on serial imaging. She eventually required hospitalization for hypoxemic respiratory failure 4 months after her initial outpatient presentation, which was 5 months from this current outpatient encounter. Bronchoscopy with bronchoalveolar lavage revealed rare non-cryptococcal yeast, but was otherwise negative for acute infectious process. A CT-guided biopsy of her infiltrated disease similarly did not show any evidence of acute infectious process and was negative for malignancy. She was diagnosed with organizing pneumonia and was discharged on a prolonged glucocorticoid taper. Her dyspnea initially remained stable. However, in the last 2 to 3 months prior to her outpatient follow-up, it was beginning to exacerbate. So her review of systems, notable for constitutional, she had marked fatigue and occasional chills, but no fever. Her eyes, ears, nose, and throat review systems were negative, including any sort of dry eyes or oral ulcerations. Respiratory, she had her shortness of breath, however, no cough or chest tightness. Her cardiovascular, gastrointestinal, and genitourinary review systems were negative. On musculoskeletal, she had complained of some arm and leg discomfort, which were felt to be myalgias. She also had noted polyarthralgias in her hands, knees, and elbows, however, denied any appreciable joint swelling. Her skin review systems was negative, and on neurologic exam, the only thing that she had noted was this non-focal weakness, but otherwise no localizing neurologic symptoms. Her psychiatric, endocrine, and hematologic and lymphatic review systems were also negative. For her past medical history, she had a history of organizing pneumonia, low back pain, plantar fasciitis, rotator cuff syndrome, and carpal tunnel syndrome. Her surgical history included an Achilles tendon repair, bilateral carpal tunnel release, hemorrhoidectomy, and a rotator cuff repair. Her family history was notable for her mother with hypertension, father with a malignancy of an unknown site, maternal grandmother, diabetes mellitus, and sister with also a malignancy of an unknown site. Social history: she lives independently in Virginia, previously employed in the healthcare field, but now retired. She has 1 dog at home for the last 12 years, though otherwise no new pets. She previously smoked cigarettes socially in her teens and 20s. She resumed smoking about a half pack to 1 pack per day within the last 18 months. prior marijuana use, previous social alcohol use, however, otherwise denied IV drug use or other recreational drug use. She recently increased the frequency of her gardening around her house near or at the onset of her dyspnea symptoms. She does not use chemicals or fertilizers, and she denies any known exposure to molds or fungi. And she denies any sexual partners in the last few years. Her medications include a vitamin D supplement at 5,000 international units daily, famotidine 20 milligrams daily, furosemide 20 milligrams daily, and prednisone 10 milligrams daily. She has no known food or drug allergies. For her physical exam, vitals included a blood pressure of 134/74, heart rate 77 beats per minute, respiratory rate 18 breaths per minute, temperature was 36.3 degrees Celsius. Her oxygen saturation was 98% on 2 liters nasal cannula, and her BMI was 25.8. Generally, she was alert in some mild distress from a respiratory standpoint. Her eyes, there were really no remarkable findings on her eye exam. On her ear, nose, and throat exam, she had some mild parotid fullness noted, but was non-painful. Mouth exam, the buccal mucosa was without any ulcers or lesions. There was no obvious JVD on her neck exam. Lymphatics did not appreciate any cervical or submandibular lymphadenopathy. Her cardiovascular exam was fairly unremarkable with a normal rate and a regular rhythm, no S3s or S4s, no murmurs, rubs, or gallops. There was 2+ bilateral lower extremity edema, which had been noticed previously. On pulmonary exam, there were bibasilar rails present. There were no wheezing or rhonchi. She had a normal respiratory effort with no accessory muscle use. Abdomen, her exam was fairly unremarkable, soft, non-tender to palpation, no rebound or guarding, and no organomegaly appreciated. On her MSK exam, it was notable for tenderness to palpation and evidence of mild joint bogginess to the bilateral MCP and PIP joints. There was also her bilateral wrists showed mildly limited range of motion. And there was also tenderness elicited with range of motion of her right elbow and bilateral shoulders. On neurological exam, she was alert and oriented to person, place, time, and situation. She had 5 out of 5 strength in her upper and lower extremities, normal muscle tone, 2+ reflexes, and her sensation was intact. And there were no findings on her skin exam. Laboratory data that we had available, her BNP showed a sodium of 137, potassium of 4.7, chloride of 105, bicarb 26, BUN of 24, and a creatinine of 1.2 with a blood glucose of 116. Her CPC showed a leukocytosis at 15.6, a hemoglobin of 11.7, platelets of 372, and a hematocrit of 48.1, with a differential with a neutrophilic predominance of 13.3. Her hepatic panel showed a total protein of 7.1, an albumin of 3.3, a total bilirubin of 0.3 with a conjugated bilirubin of 0.1. Her AST was 146 and ALT was 110, and alk phos was 68. Some serum studies to note were included a CPK of 2,227 international units per liter, a lactate of 3, a CRP of 4.3 milligrams per deciliter, an ESR of 51 millimeters per hour. Her ANA was negative, a rheumatoid factor was negative, and her hepatitis C virus antibody and hepatitis B surface antigen and hepatitis B core antibody were also negative. Her urinalysis was also fairly unremarkable with a normal pH and specific gravity. There was trace protein, but her leukocyte esterase was negative, nitrites were negative. There was some small blood, but otherwise she had negative glucose, ketones, and urobilinogen. Her red blood cells were less than 1 per high power field and white blood cells less than 1 per high power field. Some procedures from her prior hospitalization included the bronchoalveolar lavage, as I mentioned, negative for Legionella culture, respiratory culture, nocardia culture, AFB culture, as well as the nucleic acid amplification. There were some rare yeasts present on the fungal culture. However, these were non-Cryptococcus species. And similarly, the fine needle aspiration of the pulmonary infiltrate, again, did not render any sort of significant findings. And then finally, a CT chest without IV contrast recently, prior to her outpatient presentation, showed a near complete resolution of the right upper lobe airspace opacity, which was new on the previous study. There were additional scattered multifocal consolidative airspace opacities, which are not significantly changed in the previous study, with no new areas identified. There was some development of interstitial edema and a moderate-sized pericardial effusion, which was noted to be new. There was some interval increase in the bilateral pleural effusions and a prominent anterior cardiophrenic lymph nodes that had slightly increased in size. With that, I would like to go ahead and turn over the microphone to my case discussant for the afternoon, Dr. Bahnsen Miller. He is an academic hospitalist with the Central Virginia Veterans Affairs Healthcare System here in Richmond, Virginia. Prior to this role, he served as an assistant professor of medicine with the University of Virginia Health System. Dr. Miller completed his medical education at the Louisiana State University School of Medicine in New Orleans and his internal medicine residency training and chief residency at LSU in Baton Rouge. He also completed a patient safety and quality improvement fellowship at Our Lady of the Lake Regional Medical Center in Baton Rouge. And we are fortunate to have him join our joint VCU VA Medical Center and look forward to him working with the house staff in the near future. Dr. Miller. And then could we switch these?
All right, cool. Thank you so much. All right, so I'm going to go through this case using a basic diagnostic framework. One, starting out, finding some of the pertinent positives and negatives in the H&P, using that to create a problem list. And then from the problem list, I'm going to use a combination of diagnostic schema and illness scripts to really hone down on our differential and hopefully come up with the correct answer. So starting out with the H&P, I've highlighted the important positives in green, pertinent negatives in red. So starting out with organizing pneumonia, to me, this is something that's very rare. I do not see organizing pneumonia very often, but I do think, is this something that's primary, so cryptogenic or idiopathic, or is this related to another syndrome? Thinking of her new symptoms of generalized weakness and fatigue, I would want to dig a little bit more into this. We see a lot of generalized weakness and fatigue, but is there a focal component? Is this truly diffuse weakness? And then kind of what is the time frame? So is this more of an acute? Did it happen overnight? Is this more of a subacute complaint? And then seeing these two symptoms with her recent organizing pneumonia and her new weakness and fatigue, I would ask myself, are these related? Or are these two separate entities? Kind of these next points are really going through her diagnosis of organizing pneumonia. As you see, she had an extensive workup, including a BAL, a biopsy, all unremarkable for infections. So my thought process, if the organizing pneumonia is related to this new generalized weakness and fatigue, it's going to be less likely infectious. However, we cannot rule out a direct relationship between the two. And then lastly, she was on a prolonged corticosteroid or glucocorticoid taper. Several things I would question here. I would want to know, what dose was she on? How long was she on these steroids? We know some of the side effects of steroids. Is she now immunocompromised? Does she have potential relative adrenal insufficiency with a new stressor? Did she stop taking these steroids abruptly? Or is this new weakness just a side effect of her steroids? Next, you can see her dyspnea has remained stable, and her imaging has kind of mixed findings. So one side of her imaging shows improvement. Other parts of her imaging are basically stable. So my thought, if she has a worsening pneumonia or an infection or a new malignancy, you would think that would kind of show worsening signs on her imaging, especially without treatment over the last 9 months. And we're not seeing that here. She describes her weakness, and this is kind of getting into a more focal component of her weakness. She describes it as difficulty grooming herself and standing up from a chair. To me, that sounds proximal. So there is a focal component. Dating back to kind of medical school, step 1, step 2 buzzwords, when I hear proximal muscle weakness, to me, I think something like a dermatomyositis or polymyositis. Other causes are out there, but that's kind of what pops into my head first. And then her son describes pallor and cool fingers intermittently. That's pretty rare. You don't hear that often. Putting a name on that, I would say that's Raynaud's. We don't know the etiology of that. But again, putting, I think, a name on these kind of symptoms will help work through your differential. And then next in her review of systems, no fevers, no hair loss, no rashes. So, some of these are pretty nonspecific. Some of these could be autoimmune, could be infectious. We're not seeing those here. And then she does report some joint discomfort. And you see here, it's in multiple joints and joints in different sizes. So small, medium, and large joints. So that's something we need to look into as well. I would ask kind of follow-up questions. Does the pain get better the more you move in the morning? Is the pain worse at the end of the day? That can kind of help you narrow your differential. Reviewing her past medical and past surgical history, nothing really pops out. We know kind of this history surrounding her organizing pneumonia, but again, otherwise pretty routine past medical and surgical history. If you look at her family history, I would really want to dig into some of these malignancies. I wish we knew the age that her family members were diagnosed with malignancy, the type of malignancy that would help. Unfortunately, we do not have that answer. So her family history is not helping me too much here. Social history, I think this is a really good, extensive social history. Nothing's really kind of standing out. No major travel. She lives locally, no new pets, no illicit drugs. She's kind of doing some routine gardening. So all kind of typical on a social history. If you look at her medication list, vitamin D, H2 blockers, pretty benign as long as she's taking them correctly. Furosemide, potentially an electrolyte derangement. If she is taking a diuretic, that could potentially cause some weakness. I highlighted the prednisone here. Again, I would want to know what dose was she on in the past? How long was she on this medication? Did she abruptly stop the medication? Moving into her vital signs, stable, she's afebrile. This would be a point if her vital signs were not stable. We would do a lot less talking and thinking and start acting, right? Would she need fluids? Would she need antibiotics, stress dose steroids? Would she need a proceduralist or a consultant urgently? But luckily her vitals are stable, so we do have time. Looking at her ENT exam, no cervical or submandibular lymphadenopathy, so maybe less likely head and neck cancer, head and neck infection, although this does not rule out something like a lymphoma or a leukemia. 2+ bilateral lower extremity edema, very nonspecific, kind of common things, thinking of, does she have heart failure? Does she have cirrhosis? Does she have renal disease? Or is this more of just a vascular insufficiency that we often see? Her abdominal exam, pretty unremarkable. No hepatomegaly, no splenomegaly. So maybe less likely has portal hypertension with splenomegaly and cirrhosis. Maybe less likely an atypical infection, a tick-borne infection or something like EBV that could cause splenomegaly. Maybe less likely a malignancy like a lymphoma or leukemia, again, doesn't rule it out. I think her MSK exam really sticks out to me. Hearing the term bogginess, I think of inflammatory. So we know arthritis can be non-inflammatory or inflammatory. So it sounds like she has a polyarthritis, right? In multiple joints, small, medium, and large joints. And seeing that it's pretty specific to the MCP and PIP also sticks out to me. Kind of back to the medical school days, buzzwords, thinking of rheumatoid arthritis, more MCP and PIP versus a DIP, which would be associated with osteoarthritis. So I think that is interesting, something maybe autoimmune going on here with her polyarthritis. Interesting, her neuro strength is 5 out of 5. She reported some proximal muscle weakness, difficulty getting out of a chair. I would want to dig into that a little bit, maybe re-examine her and see if her strength is truly 5 out of 5. Going through her labs, her chemistry is unremarkable. Creatinine 1.2, that may be a little elevated for an older female. I'd want to know some previous, but otherwise pretty unremarkable. I see her AST and ALT are slightly elevated. So does she have a little liver injury, transaminitis potentially? Because of her alk phos is normal, I would say this is more of could be a hepatocellular type injury. Her bilirubin's normal, and from what I can tell here, her synthetic liver function is also intact, so less likely cirrhosis. Total protein is normal as well, thinking of things that can cause a protein gap. Her CBC, pretty unremarkable, maybe a slight elevation in white count. Looking at her diff, I think is something we often overlook sometimes. It's especially important to evaluate in some of these zebras or some of these cases when multiple organs are involved. Eosinophils, I think, are something to look at. Luckily, hers were unremarkable on her diff. If her EOs were up, you would think of maybe something parasitic, something malignant related. Her UA is also pretty bland, does have small blood on dipstick, but her red cells are negative. So maybe something like an elevated CPK or a rhabdo going on. RBCs are often overlooked as well. If she had a vasculitis and she had RBCs, that would be an urgent involvement in your nephrology colleagues. So luckily, she does not have any red cells on her UA. Looking at her serum studies, her ANA was negative. That pretty much rules out lupus. Otherwise, ANA pretty nonspecific. Her rheumatoid factor being negative doesn't tell me too much. We know rheumatoid arthritis can have a negative rheumatoid factor. Her CPK is elevated. This is interesting. So this is probably explaining the elevation in her AST and ALT. So it's probably not coming from liver, thinking skeletal muscle. Lactate slightly elevated, inflammatory markers elevated, pretty nonspecific. Some of her infectious, Hep B, Hep C negative. And then the BAL and FNA, these are studies that she had on her previous diagnosis of organizing pneumonia. Very extensive workup and all negative for infection or malignancy. So likely it was labeled cryptogenic at that time. The imaging, things that kind of stood out to me on this, looks like the one opacity was better, so almost resolved. And then some of the other airspace opacities were about stable, right? So she was only on steroids since that previous diagnosis. So if she had a malignancy or if she had a new infection, I would expect new findings, at least in the pulmonary or in the parenchyma on imaging. What is new though, she does have a pericardial effusion and bilateral pleural effusion. So we need to dig into that a little more. Okay, so this is just a basic problem representation. So I would expect a third or fourth year medical student to be able to piece this together, kind of a summary statement of what we've heard so far. So I'll just say it here. We have a 71-year-old female, recent diagnosis of organizing pneumonia, presents with several weeks of worsening fatigue, weakness, dyspnea, joint pains, cool fingers intermittently. On labs, found to have an elevated CPK. On imaging, she had pulmonary edema, pericardial and pleural effusions. And then the previously seen multifocal consolidative airspace opacities were mostly stable, okay? You can make this a little more nuanced if you want to put names on some of these symptoms, but this is a good start. So how do we arrive at a diagnosis? We've heard many conditions that sound infectious. We've heard some that sound autoimmune, heard some that sound malignant. So how do you kind of get out of this spiral and actually come to a diagnosis? And this is kind of a branch point within this case. So my suggestion is to start with some objective findings. Start with findings that we had in our H&P, create a problem list, and from that problem list, work through the differential on each. So this is my problem list. Patient recent diagnosis of organizing pneumonia, proximal muscle weakness, elevated CPK, Raynaud's, polyarthritis, and pericardial and pleural effusions. When you do make a problem list, you have to ask yourself, are these things related or not? In this patient with a rare condition, and then several months later had several other kind of symptoms present around the same time, I would most likely say these are more than likely related. Maybe not all, but I would say most of these are related to each other on the problem list. So I'm going to go through each one of these on the problem list. We're going to go through a differential or schema for each one. And as we go through, I want you guys to kind of see if there are any recurring themes, and that'll help us form our differential. So as I mentioned before, organizing pneumonia can either be cryptogenic or a secondary cause. This is a New England Journal paper that was recently published that lists out secondary causes of organizing pneumonia. And based on the information we have on our patient, we can already rule out several of these etiologies. Drugs, we can rule out. She's not a transplant patient. She did not have recent radiation. We know her infectious evaluation was extensive, and we know she doesn't have any new findings on her CT of her chest from a lung standpoint. So I would say infection is probably a lot lower on the list. Now, again, cryptogenic or her organizing pneumonia may not be infectious, but we still have to consider her new symptoms being the weakness could potentially be infectious. Connective tissue disease, this is interesting. Kind of what popped up initially with her proximal muscle weakness was a thought about dermatomyositis or polymyositis. So I think this is moving up a little bit on the differential. Some malignancies we can't rule out yet, leukemia, lymphoma, something to consider. I would put kind of association with other lung diseases lower. Again, she did have extensive imaging. She had a BAL, biopsy. These would have usually shown up on those studies. IBD, we know you can have extraintestinal manifestations of Crohn's. She may not be having GI complaints. but potential. So we can't rule out IBD at this point. Kind of moving on to our next part of our problem list, this patient's proximal muscle weakness. I borrowed this schema from a colleague in residency, and she kind of took an anatomical approach to weakness, being the nerve itself, the neuromuscular junction, or the actual muscle. And our patient, I would say muscle, right? She had an elevated CPK, she had weakness that was proximal. So we really need to dig into what can cause proximal muscle weakness with an elevated CPK. And so my approach to elevated CPK is going to be traumatic versus non-traumatic. We don't have any evidence or anything from the history that this is traumatic, right? So I would go down the non-traumatic pathway for her. Drugs, toxins, she's not on a statin, no cocaine use that we know of, no snake bites. So I would say drugs or toxins are less likely. A note on her steroids, as I mentioned before, steroids can cause weakness. Typically your CPK would be normal in a steroid-induced myopathy. So that's pretty much off the table at this point. Genetic causes, you would expect her CPK or her to have rhabdo or some other muscle symptoms earlier on in life. Infection is popping up again. Infections can cause an elevated CPK, but I would say in her case, if she had strep, staph, E. coli, Legionella, she would be pretty sick. Some of these viral infections, you would expect to see something on labs, something on imaging, or have other clinical symptoms. But again, it's kind of hard to rule out at this point, especially if it's not related to her organizing pneumonia. Other causes, metabolic, her electrolytes look fine, so that's less likely. Potentially hypothyroidism. We don't have a TSH, it would be nice to have, but hypothyroidism can cause elevated CPK, although rare. And then here we go, the inflammatory myopathies. As we mentioned, kind of this proximal muscle weakness, rheumatologic causes of organizing pneumonia, also known to have or cause elevated CPK. Several things can do it, dermatomyositis, polymyositis, or as part of kind of an overlap or part of some of these other connective tissue diseases, as you see here, lupus, Sjogren's, RA. Sarcoid is on this list. You would expect if this patient did have sarcoidosis, some lymphadenopathy, rash, or other findings. Not seeing that here. Amyloid as well, you would expect her to have maybe a CKD or a neuropathy. So I would put amyloid a little lower on the list. Behçet's, typically ulcers, you would see. Again, that's kind of lower on the differential. But as a whole, after these two kind of symptoms, I would say rheumatologic, autoimmune, or inflammatory is higher on the list. Kind of moving to polyarthralgia. She had bogginess, so I would say polyarthritis for this patient. So polyarthralgia, inflammatory, non-inflammatory. I would say she goes down the inflammatory route. Infections can cause both. These infections would be a lot less likely in her. Lyme, you would expect to have a rash or maybe larger joint, not this kind of symmetric MCP, PIP. She was Hep B and Hep C negative, no evidence of parvo, rash, or CBC, and no travel. Some of these seronegative spinal arthropathies are out there, ankylosing spondylitis, psoriatic arthritis. These are going to give you more of an axial type arthritis, less likely peripheral only, less likely some of these kind of small joints. And reactive is on here as well. No recent signs of a GI illness or a recent infection. Sarcoid, we already talked about. Rheumatologic, again, can definitely cause polyarthritis, and we'll go into a little more detail later. Crystal-induced, like gout, less likely. And so next would be Raynaud's. So we mentioned earlier, she did have these symptoms that were pretty rare, but pretty specific for Raynaud's. And so it's either going to be a kind of a primary etiology that's kind of idiopathic, or it's going to be secondary to another condition. So no evidence of environmental or trauma. From an intravascular standpoint, hematologic causes could present with Raynaud's. Again, Hep C was negative, total protein was fine. So these are going to be like a lot less likely. Vessel wall conditions such as hypothyroidism, could do it. I still want that TSH, no evidence of drugs that we're aware of. And then autoimmune conditions, specifically the ones mentioned here, can cause Raynaud's. As you notice, infections typically do not cause Raynaud's. So as we saw, infection was lower on the list for organizing pneumonia. We were thinking if this weakness was something new, infection was still on the table. But after seeing this, I think infection is extremely low on our differential at this point, and autoimmune is coming up to the top. Lastly, just to finish out her problem list, pericardial disease, she did have a pericardial effusion that we noted. Cardiac, no evidence of a recent MI or cardiac injury. Other medications can do it. We're not getting evidence of that. Hypothyroidism, we're still waiting on that TSH. Malignancy certainly can. With her age, with her family history, I would really be concerned about malignancy or maybe a paraneoplastic syndrome causing some of these symptoms. We only have a CT of her chest, no evidence of malignancy, but still I would keep that on the table. And then of course, the autoimmune causes of pericardial disease. So how do we get to our differential? And as a reminder, this is our problem list: organizing pneumonia, proximal weakness, elevated CPK, Raynaud, polyarthralgia or polyarthritis would probably be more appropriate, and then the pericardial and pleural effusions. So autoimmune or rheumatologic is at the top of my differential, and specifically within those, the idiopathic inflammatory myopathies. The kind of waters are muddy with some of these diagnoses, and I look forward to hearing from our expert. But dermatomyositis, polymyositis, antisynthetase syndrome, and then, you could have more of these symptoms from an overlap, someone with lupus or Sjogren's or scleroderma or mixed connective tissue disease. So on the next slide, I'll dig into this a little more using illness scripts. I want to round out kind of some of these other conditions that popped up in these schemas that we should consider, or at least talk more about to take off the table. One, hypothyroidism. Again, no TSH, but hypothyroidism can cause myalgias, elevated CPK, proximal weakness, but typically you would have other signs of hypothyroidism. You wouldn't expect lung involvement in hypothyroidism either. Vasculitides, several, I think, are worth coming up. We know vasculitis can do a lot of different things. An ANCA-associated vasculitis can obviously cause inflammatory arthritis, pulmonary infiltrates, but you would typically have some upper airway or sinus, sinusitis or involvement of the sinuses, and you would typically have red blood cells on a UA. PAN, polyarteritis nodosum, can also give you malaise, arthralgia, but it's more of a kind of a lung infarct, I guess you could say. And you would expect to have cutaneous findings, some neuropathies, hypertension, GI symptoms. Behçet's can do several of these, but typically the arthritis is going to be larger joints and associated with ulcers. PMR, this is kind of another buzzword when I think of kind of proximal muscle, but PMR is going to be less proximal muscle weakness, more of a kind of a pain. But it's treated with low-dose steroids. It usually responds very well to low-dose steroids. This patient was already on steroids. So this is lower on the list, especially you would expect to have a normal CPK with PMR. Reactive arthritis, we didn't really have an evidence of infection, like a preceding viral GI illness. Typically, you would have axillary involvement and the joint pain would be a little more asymmetric. Viral arthritis, again, no great evidence of an infection. So I think viral arthritis would also be off the table. So diving a little more into these idiopathic inflammatory myopathies. So I think we're getting close to our diagnosis. We're not there yet, but we're getting close. Dermatomyositis really fits a lot of these boxes. So older female, lung involvement, Raynaud's, proximal symmetric muscle weakness, arthritis, myocarditis, CPK elevation, negative ANA. However, dermatomyositis, you would expect to have a rash, heliotrope rash, Gotron papules. So I would take that off. However, I think of the DM's cousin, polymyositis, is very similar without the rash. So this pretty much checks all the boxes, but I think we need to go through a few more. Inclusion body myositis, the IBM here, that's more of a distal atrophy. So our patient had proximal. RA, rheumatoid arthritis. If you're going to have lung involvement with RA, your rheumatoid factor is going to be strongly positive typically. And the RF in our patient was negative. Also rare to have elevated CPK in RA. So I think RA can move down a little bit. Scleroderma is here. Scleroderma, you would typically see skin findings, which we do not have. And then the ANA is usually positive for scleroderma. Sjogren's, no reports of a dry mouth, dry skin, dry eyes. So not really getting anything Sjogren's related. Mixed connective tissue disease fits a few, typically younger patients, more pulmonary hypertension, not as much parenchymal lung disease, and the ANA or rheumatoid factor are typically positive in mixed connective tissue disease. And this leads us to our last condition, anti-synthetase syndrome. It also fits a lot of the boxes, very similar to polymyositis. One thing you don't have in our patient is mechanics hands, which is another kind of buzzword for anti-synthetase syndrome. It's kind of a hyperkeratosis, dry hands. Don't see evidence of that on our patient. But after reading a little bit about anti-synthetase and polymyositis, it seems like polymyositis can be part of anti-synthetase syndrome. Very interested to hear what our expert says. To kind of nail the diagnosis, I would want to have a myositis panel. There are many anti-synthetase antibodies out there. I think that would be very helpful. These are two kind of guidelines or kind of ways to kind of come up with this diagnosis from Connors and Solomon, and they each require the presence of a anti-synthetase antibody. But as you can see here under Connors diagnostic criteria, Raynaud's, arthritis, interstitial lung disease, patient didn't have fever, didn't have mechanics hands, but you don't need all the criteria. And then Solomon mentions having polymyositis as well on top of interstitial lung disease or arthritis or Raynaud's. So I think my final diagnosis is anti-synthetase syndrome. We'll find out. And then before I stop, just a few broad key takeaways for diagnostic reasoning. I think it's important to have a strategy, use a framework or system type approach. Understand this is a team sport, including your patient. So go back to your patient a couple of times and talk to them, get more history, do another physical exam, talk to family. Family can be so important in the diagnostic reasoning front. Also want to give a shout out to a couple of colleagues, a former resident colleague, Ross Thibodeau. He's a rheumatologist. He helped me out a little bit with this case. Y'all know Dr. Abi over at the VA. He was extremely helpful on this case. So consult your colleagues. They can help tremendously. Trust, but always verify a diagnosis. You may have patients come to you with a certain label or a certain diagnosis. Kind of look and see what the workup was to make sure it was the correct diagnosis. Also understand in cases like this, diagnoses sometimes evolve over time. So this patient only had kind of the pulmonary stuff at the beginning, and then over time had kind of these extra pulmonary symptoms. When you're working on a differential, start broad, thinking of kind of the can't miss diagnoses, even though may not be most likely. Think of things that could the patient could decompensate quickly from, and then narrow from there. Consider a problem list like we did. Putting a name on certain symptoms can actually help work through a differential. Be aware of cognitive bias. We didn't get into that much here. I know you guys have had some really good lectures on cognitive bias. And then also understand the limitations of diagnostic testing. We do so many tests. Understand what you're going to do with that test if it's positive. How's it going to change your management? Understanding pretest probability and other testing characteristics is very important. So with that, I'll turn it over. Thank you so much for your attention. And I look forward to hearing what some of the others say.
Thanks so much, Dr. Miller. Dr. Parker, I believe you are on the call, and we will go ahead and stop our share. That way you can share your screen.
Okay. Can you see the images okay?
Yes, we can.
Okay. Any audio is coming through, Craig? All right. This patient, interestingly enough, has not ever had a chest x-ray done, but has had 9 chest CTs performed between July 30, 2021, and the most recent CT examination of May 5, 2022. For the sake of time, I obviously will not go through all of those, but I will focus on 6 of these, which highlight the key imaging features of this disease process and its evolution. The very first CT scan before you is her baseline examination from July 30, 2021. If you look at the right-hand screen, which are the soft tissue mediastinal images, you'll see her thyroid looks fairly unremarkable. There's no anterior or superior mediastinal mass. Her main pulmonary artery is not enlarged. And there's no pericardial effusion at this point in time. She does have a small dependent layering right pleural effusion. And if we scroll back up top, you can see she does have some borderline size of slightly enlarged lower left, lower right, subaortic, subcarinal, and a very generous right hilar lymph node. Upper abdomen was unremarkable. Her lung windows are much more interesting. If we scroll through the upper lung zones, you can see there's evidence of right upper lobe airspace disease with concomitant volume loss and subtle areas of evolving cavitation necrosis in the right upper lobe airspace disease. This disease extends into the right middle lobe with associated peribronchial vascular bundle thickening and traction bronchiectasis. So right upper lobe airspace disease, consolidation surrounding ground glass, areas of cavitation. You can also see there is disease evolving the apical posterior segment of the left upper lobe. And as we scroll down into the lower lung zones, patchy, predominantly peripheral and peribronchial ground glass in the right lower lobe and evolving nodular areas of consolidation in the left lower lobe. The next CT scan I'm going to go through is from August 29, about 2 months later. And at this point in time, you can see the right pleural effusion has markedly enlarged, extends from the apex all the way down the posterior recess and is demonstrating early loculation. The lymph nodes have progressed, reacting to the pleural disease. The right upper lobe airspace consolidation has progressed, as has that in the right middle lobe. And she's developed a trace amount of pericardial fluid. She does have some very small to borderline sized right hemodiaphragmatic surface and pericardiac nodes, which were mentioned in your early presentation. If we look at the lung windows, again, they look much more interesting. We're seeing progressive volume loss in the right upper lobe and right middle lobe, progression of the traction bronchiectasis. The areas of cavitation are contracting, but the bronchiectasis has progressed. The disease in the left upper lobe has not really changed significantly. But now we have new disease evolving in the lingula, ground glass and septal thickening, evolving consolidation. And you can also see we're developing progressive consolidation in the left lower lobe now. And if you look at the right lung base, you see also airspace disease, bronchiectasis, and development of septal lines with stretching the bronchi and airways with early fibrotic changes. I will skip the September 3rd, 2021 examination because it didn't really show any significant changes other than increasing left pleural effusion. We'll jump now to the September 17 examination. I'm sorry, September 12 examination. And you can see this is an unenhanced examination. We still have bilateral pleural effusions come right greater than left. They have slightly decreased in volume. We have a trace amount of pericardial fluid, but it's slightly larger. The lymphadenopathy has not really changed. If we look over again at the lung windows on the right-hand side of the screen, we see progressive mass-like consolidation in the right upper lobe, but progressive traction bronchiectasis, surrounding desmoplasia. These are all features that we expect to see with an organized pneumonia with fibrosis, as was discussed. You can see also the traction bronchiectasis and varicoid bronchiectasis. The apical posterior segment left upper lobe disease has improved. As we scroll down to the lower lobe disease, we get into lingula consolidation has improved more superiorly, but progressed more inferiorly. We have progression of interlobar septal thickening. The area portions of the right lung and middle lobe demonstrate progressive interlobar septal thickening. And you can see the bronchial vascular bundles, interlobar septal becoming more coarse and thickened in the lower lobes. And we're developing progressive interlobar septal thickening and traction bronchiectasis. You can see that nice illustrated here. The right lung is involved out of proportion to the left lower lobe. I will skip the examination from September 17th for the sake of time, and that from October 29 as they showed no real significant changes. The next one I want to share with you is from December 27. And the December 27 examination demonstrates persistent bilateral pleural effusions. As you can see, the right again is greater than left. There's loculation along the costal pleura of the right hemithorax. And we still had the persistent pericardial effusion, which is now larger. Okay, initially not present, then got a little bit, then declared itself and has become larger over time. No real change in lymphadenopathy. If you look at the lung windows, we see ongoing volume loss in the right upper and middle lobe. This is becoming more organized, contracting, developing progressive fibrosis. Again, consistent organized moaning with associated fibrosis. The disease in the apical posterior segment left upper lobe is pretty much resolved. If we get down the right middle lobe, we can see interlobular septal thickening and also interlobular septal thickening in the lingula. The consolidation, however, has resolved. We do see coarse interlobular septal thickening and bronchovascular bundle thickening in the lower lobes, stretching the airways of the evolving fibrosis. It does go all the way out to the pleural surface. You see nice irregular septal lines through the right lower lobe here. Despite the traction bronchiectasis, we don't see any evidence of honeycombing at this point in time. The next examination is from March 15. This was actually a dedicated HRCT examination, associated inspiration and expiration imaging, prone and supine imaging. For the sake of time, I'll tell you that there was no evidence of air trapping in expiratory imaging. On the soft tissue windows, you can still see a large right pleural effusion. It's loculated in nature. Some lymph nodes have waxed and waned, borderline to slightly enlarged in size. The largest one was again persisting in the right hilar region. No change in diameter of the pulmonary arteries, no anterior mediastinal masses. The pericardial effusion again is somewhat larger and becoming loculated along the right ventricular free wall. You mentioned the pericardiac nodes. These have waxed and waned a little bit. Initially were not present, got a little bit larger and got a little bit smaller, then got a little bit larger and then got a little smaller. So they kind of waxed and waned over the series of examinations. Despite the history you had that they were new, they have actually been present. The image I'm showing you in the lungs over here actually is a prone image. You can see actually the CT table is here. So the patient's lying on their stomach. And this allows us to expand the lower lung zones and see what's going on in the basis to better advantage. You can see on the HRCT imaging the fibrotic changes here in the right upper lobe, distortion of the oblique fissure, the traction bronchiectasis, how this is becoming balled up into a mass-like region of fibrosis, the associated traction bronchiectasis, et cetera. And again, continues down into the right middle lobe. The prone image is also nice to illustrate the interlobular septal thickening that we're seeing, not only in the inferiormost portion of the lingula, but in particular the lower lobes. And it also nicely depicts the traction bronchiectasis that we're seeing in the lower lobes, the interlobular septal thickening, the stretching of the vessels all the way out to the pleural surface. But it does go all the way out to the pleural surface. There's not juxtapleural sparing. And most importantly, we can see that there's no evidence of concomitant ground glass or consolidation of the lower lobes or evidence of honeycombing. And then the last CT examination we have on her is from May 15, so about 2 months later. The right side of pleural effusion has again enlarged. She now has a new small left pleural effusion. And the pericardial effusion has become slightly smaller in overall size. Again, some waxing and waning in the mediastinal and higher lymph nodes. There's been a slight upward trend in the nodes. If we scroll down to the pericardiac region, these nodes are slightly larger, reacting to the pleural and parenchymal disease. If we go back to the lung windows, things have gotten more interesting again. Now we can see the superimposition of diffuse ground glass. We have airspace opacities. We can still see the vessels and bronchi through, as opposed to consolidation, which obscure the vessels and bronchi. We have the chronic volume loss in right upper lobe with the organizing fibrosis and traction bronchiectasis, but that active disease process in that region of interest is for the most part resolved, and it's now just fibrotic. You can see the ground glass associated bronchodilation extends into the lingula, the right middle lobe, and throughout both lower lobes, again, the associated peribronchial vascular bundle thickening, traction bronchiectasis, and now we're seeing juxtapleural sparing, which is a pattern that we can see here with the reticular opacities parallel the pleura, but not kissing the pleura. So the upper lung zones receive features of the resolving organized ammonia now with fibrosis. In the lower lung zones, we're seeing evidence of what we refer to as a pattern that is not typical or expected for UIP and more suggestive of a NSIP pattern, but there's now a superimposed acute process with diffuse ground glass to the lungs. So we initially began a multi-lobar acute multi-mnemonic process involving the right upper lobe, middle lobe, and both lower lobes, pattern ground glass consolidation, no lymph nodes, no pleural effusion, no pericardal disease. Then it progressed to having borderline size of slightly enlarged mediastinal and high lymph nodes over the series of examinations, right upper middle lobe organized with fibrosis, but a predominant pattern of lower lobe interstitial lung disease characterized by peribronchial vascular thickening and interlabial septal thickening, retraction bronchiectasis, a non-UIP pattern, and no evidence of honeycombing.
Thank you so much, Dr. Parker, for walking us through those radiographic findings. We're really fortunate to have you join us today. We appreciate it.
You're quite welcome.
And with that, I believe Dr. Gavin is on the call, one of our rheumatologists who currently practices at CMH and is a graduate of the VCU Rheumatology Fellowship. Dr. Gavin, if you'd like to share your screen if you're able, and the floor is yours.
All right, am I coming through it all?
Yes, you are.
All right, sounds good. So, I mean, shout out to Dr. Brian. That was masterfully done. I really appreciate all those clinical reasoning pearls. Yeah, I mean, there's a lot of good tidbits in there. I really appreciate the points about kind of comfort within diagnostic uncertainty. I think that's a huge thing in rheumatology, and this kind of evolution of diagnosis is a big thing, especially as the diagnoses kind of evolve around us. So yeah, I think he did a stellar job, and we'll kind of walk through, and yeah, I very much agree with his final conclusion. So so synthetase syndrome, yeah, much more than a myopathy. He kind of referenced this kind of concept of this murkiness, and I very much agree with that. I think there's starting to be a little bit more clarity in terms of how we view synthetase syndrome in general and myopathies in general. And this is a very helpful perspective that I kind of use a lot and reference a lot. And I just kind of refer to it as the circles of the myositis antibodies. And I think we tend to look at the myopathies now much more from an antibody and manifestation perspective than from a just PM, DM, or IBM type thing. So you can kind of see this Venn diagram with all these overlapping circles. And obviously this is alphabet soup and very overwhelming, but if you look at it a couple of times, it can be very helpful and break things down. And one thing you'll notice is what is not in here is polymyositis. And I think that's kind of tending to be a trend currently with a lot of rheumatologists who specialize in this area, is that the more we discover these synthetase antibodies and these antibodies like IBM, this 5-MT1A, and these HMG-CoIR reductase antibodies and all of these different things, the more polymyositis shrinks and the more people question whether it even exists. And so I think that is kind of a bit of a push towards potentially taking away PM altogether and focusing more on the antibody and the clinical phenotype. So here's the synthetase syndrome, which kind of exists in this circle between lung disease, overlaps into the skin disease, and then some of this connective tissue disease phenotypes as well, which we'll get into also. So, but yeah, I find this a really helpful Venn diagram anytime we're thinking idiopathic inflammatory myopathy. Right. So what are the synthetases? They are intracellular cytoplasmic enzymes that play a critical role in protein synthesis. And cytoplasmic is important. Like he mentioned, the ANA was negative. So ANA, anti-nuclear, that's something to keep in mind. You know, you don't want to rule this out just because your ANA is negative. It may be positive, but most of the time, this is going to be a cytoplasmically active antibody, so it's not going to pick up on that immunofluorescence of the ANA screen. So specifically, we're talking about these aminoacyl transfer RNA synthetases. They attach amino acids to this tRNA molecule, which then prepares this peptide chain. And so there's 20 of these apparently. And so far, we have 11 autoantibodies that have been identified, and I think 7 or 8 of them that we screen for clinically now. And each of them targets one of these unique synthetases. And I learned this when looking stuff up for this, but synthetase versus synthase, The synthetase means you need a ATP, you need energy for the binding to occur. So, the Jo-1 is the kind of primary example of tRNA synthetase, and this incorporates histidine into the proteins. And then the PL12, which is another one of these, targets the alanine tRNA synthetase, so which incorporates the alanine. So they all have a very specific target. And then these are the known antibodies, like I just mentioned, Jo-1, PL7, PL12, OJ, EJ. I think those are probably the 5 original, and these are the emerging ones which have been found in kind of some clinical trials, but we can't yet test for those. So the whole concept of seronegative synthetase syndrome is something to keep in mind. There's 20 of these. We can only test for 5 to 8, depending on which lab you send it to. And so there's another 11 or 12 missing. So that's definitely something that's possible also. So this is a super rare disease. Data is almost all case series and case reports, mostly women, like the rest of our autoimmune diseases. But the big thing about synthetase syndrome is when you look back at a lot of these retrospective series, many of these people were misdiagnosed with an idiopathic pulmonary fibrosis, DM, or PM. And that's often because they didn't have the antibody to test for the original diagnosis. But because of that, prevalence and incidence remains pretty much unknown. If you look at the incidence of PM and DM, it's about 2 to 10 per million person years. And it seems to be about 30% of that tends to be antisynthetase syndrome. So clinical features, the hallmark symptoms are the fever, myositis, interstitial lung disease, the inflammatory polyarthritis, as Dr. Brian Berry artfully picked out, and then the Raynaud's and the mechanics hands, that hyperkeratosis that he mentioned as well. And so I think the very important thing to keep in mind is looking back at a lot of these other case series and case studies, I would say probably most of these patients present with an antibody and one of these symptoms. There's a case series where it was a group of patients who were presented as seronegative rheumatoid arthritis, and they were treated for years until they developed one of the other features, and then they had their antibodies tested, and it turns out they were Jo-1. So it's very important to kind of keep this in mind, because things do evolve and change, and if you have an additional feature, you should always revisit your diagnosis. So avoiding anchoring is key to making this diagnosis. And this is from that study I just mentioned that talked about those patients who were originally diagnosed as rheumatoid arthritis and then went on to develop these other symptoms. But I thought what was interesting about this cohort was the serositis, which our patient very much had. 4 of their 15 at presentation had the serositis, and the serosa, the lining of these internal and external membranes kind of thing. So that I think probably explains a good portion of her pericardial effusion and her pleural effusions. So that's definitely kind of one of those overlap phenotypes that she had. And then, like Dr. Brian already beat me to, these are the major diagnostic criteria. I think people tend to use the Connors one. It's a little easier to meet the criteria as more of a diagnostic criteria, and the Solomon tends to be the stricter one that's tend to be used a little bit more for publications and that type of thing. But I think they're both very similar in terms of their accuracy for diagnosis for this disease. Ultimately, these antibodies are quite sensitive and quite specific. And if you have an antibody plus any of these, I think the suspicion that they have an underlying antisynthetase syndrome is very, very, very high. So this is, Raynaud's is a vasculopathy. And so neofold capillaroscopy can be a really useful bedside physical exam tool to really look at this and get some kind of more concrete information about that. And so this on the far left over here is a patient with a primary Raynaud's phenomena. You can see maybe a tiny bit of dropout, but you don't see anything major abnormal. There's a nice clean line of the capillaries. There's nothing that's particularly dilated or anything major going on here. So then when you go here, you get a little more into the connective tissue disease phenotype, and you get this angiogenesis, this angioproliferation, these dilated vessel walls, and probably a little bit of dropout as well. And kind of same thing over here, you can see this microhemorrhage, these giant capillary loops, and then just kind of distortion of the regular vessel membrane. And that's kind of definitive of that vasculopathy that you see in Raynaud's. And so that helps you differentiate. Is the Raynaud's really a part of this connective tissue disease process, or is the Raynaud's maybe a red flag and not, or a red herring and not particularly useful in this diagnosis? So that can be it's a relatively easy thing to do. You can get a jeweler's loop, put a drop of oil on the nail fold, and you can go in and look at it and see yourself. It doesn't take that much practice or training to get to at least tell normal from abnormal. Obviously, there can be plenty of nuance to it. And this is some of the other features. This is the Raynaud's from a gross perspective. And this is a really severe case of the hyperkeratosis. I've never seen anything this dramatic. It tends to be much more subtle in the few cases that I've actually seen, and much more of just a mild, almost eczema-like, distal eczema-like appearance in the fingers. Although a very prominent thing will be a lot of the periungual changes right around the nail fold, which this patient doesn't really have as much of. So treatment, first line steroids, like, it seems to be all of our rheumatic diseases, usually pretty aggressive, especially if they have pretty rapidly progressive lung disease. That's always the biggest concerning thing. So those patients would probably get pulse dose. But if they don't, if they have more of a slower course, not requiring hospitalization, and this is an outpatient, then probably about a mg per kg and taper them over a couple of months while you're adding in one of these steroid sparing agents. So once again, if they're having a less malignant course, then I think you can add in these steroids or these steroid sparing agents like the mycophenolate especially, although there's a bit of a quandary in synthetase syndrome because it's not as effective for the joints, or really doesn't do much at all for the inflammatory arthritis component. So that's when, AZA or methotrexate can become a little more appealing. Methotrexate, there's always that, mild, rare, scary concern of the hypersensitivity pneumonitis, which can also, would obviously confound things. And then cyclophosphamide and tacrolimus, there's a couple studies looking at, and I say studies, small case series looking at cyclophosphamide for rapidly progressive ILD, which would be somewhat similar to this patient that showed some good prognosis. But I find that rituximab and IVIG tends to be where we're headed more nowadays in lung transplant if things progress to the point where they're not responding to treatment anymore. So, it makes sense. It's a bit of an antibody-mediated process. So Rituxan has a lot of appeal, although the data is still very mixed and it's very, very challenging to study because it's such a rare disease. But I think the one tip that Reed left out that wasn't in any of this was she was Jo-1 positive. And it looks like on her chart review, she was actually Jo-1 positive very early on in disease. When her initial hospitalization, they found it. She did, I think, see rheumatology and get started on CellCept and did have a very severe course. I think that's all I've got.
Thank you so much, Dr. Gavin. We appreciate that. And I apologize that my preamble ran a little bit longer. I wish I had more of an opportunity to open it up for questions. I will be happy to hang around for a couple minutes. I know Dr. Gavin's in clinic, so I imagine he has to go. I want to also thank Dr. Parker for joining us today and reviewing the images, and congratulations to Dr. Miller on the correct diagnosis.